welcome. Thank you all for being here, and great to have everybody here with us here today for today's Medical Alley webinar titled Maximizing Medicare Reimbursement in the Hospital Setting. My name is Ben Wagner. I'm the Associate Director of Communications here with Medical Alley and your host for today's conversation. First, I want to extend a special thank you to the McDermott Plus team for sponsoring today's program, really in their continued partnership with Medical Alley. The team with us here today brings deep expertise in healthcare policy and reimbursement. We are really excited to have them leading today's discussion. Today's conversation really will explore how hospitals and manufacturers can strengthen their reimbursement strategies, really in an increasingly complex policy environment, from understanding Medicare's inpatient payment structure to leveraging NTAP and preparing for proposed policy changes that really could reshape reimbursement models. With us here today is Marla Kugel, a Senior Director at McDermott Plus, who is nationally recognized for her 20 years of experience in advising stakeholders on healthcare payment and quality policy, particularly the Medicare inpatient and hospital outpatient prospective payment systems. Also with us here today is Devin Stone, a Senior Director and a skilled healthcare data analyst who uses his deep programming skills and expertise in healthcare payment systems to support clients' strategic decision-making and advocacy efforts. And finally, Parasha Patel is a principal at McDermott Plus and an accomplished healthcare executive with more than 30 years of experience in health policy and market access. So we are thrilled to have this team with us here today to share their insights and their practical guidance, and for you to be able to ask questions of this group here as well. So with that, I will turn it over to Parasha with the McDermott Plus team to get us started.
Thank you very much, Ben. Appreciate that. And thank you for hosting us today. And thanks to the participants that are on the call. I'd like to provide a little bit of background on McDermott Plus before I turn it over to Devin and Marla. McDermott Plus is a consulting firm primarily based in Washington, D.C. I joined McDermott Plus about 2 years ago. And the reason I joined were the wide breadth of services that we can offer clients. We have not only a market access team, we have a data analytics team, of which Marla and Devin are co-leaders. We have a policy team as well as an advocacy team that lobbies the Hill. And so for my clients, I'm able to provide as needed services, not only on typical market access topics like Medicare payment policy, private payer Medicare coverage issues, but also, if necessary, put in the occasional effort on the Hill to move issues along with CMS and other instances. So with that as background, let me turn it over to Marla and Devin. And I think one thing that we'd like to encourage is let's make this as interactive as possible. If you've got questions, please put them in the chat, as Ben said, and we'll try to get to as many as possible as quickly as possible as well. So with that, Devin, let me turn it over to you and let's get started. Thank you.
Sounds good. Thank you, Parasha. All right, so to give a little roadmap in terms of our presentation today, I'm going to start off talking about the rulemaking process that CMS uses for updating and establishing payment rates for the Medicare fee-for-service program. And then I'm going to hand the microphone over to Marla, who's going to discuss the new technology add-on payment program, as well as various policy proposals that might impact payments and impact the site of service where care is often received. All right, so at a very high level, in terms of the key themes we want to get across in our presentation today, the very first theme is that we want stakeholders to be proactive. So this means that if you're a hospital or a health system or a medical device company, you want to be aware of the proposals that CMS is publishing in their proposed rules, figuring out if it impacts your service lines or if it impacts your technology or your device, and making sure that you are commenting on those proposals and that you are using data to support your advocacy efforts when you comment on those proposals. For medical device manufacturers specifically, it's also important to think about any payment pathways that might benefit your technology. So for those technologies that are used in the inpatient setting, the new technology add-on payment program is something worth considering. And that's something that Marla will be discussing in her slides. The second key theme is it's important to understand how the market is changing for healthcare. So as an example, every quarter, we here at McDermott Plus purchase Medicare claims data from CMS, or the Centers for Medicare and Medicaid Services. We currently have data through the first quarter of 2025, and in mid-November, we'll have claims data through the second quarter of 2025. And this data is incredibly useful from a market access perspective, because it's a chance to see how volume is changing for particular service lines or for certain types of technologies. It's also an opportunity to see how hospitals are billing for those technologies. One of the things that we'll talk about later in this presentation is that it's important that hospitals and health systems bill appropriately for the technologies that they're using, because if they fail to bill appropriately, that can impact payment rates for those technologies moving forward. And this is also incredibly useful data for advocacy efforts in terms of telling your story to CMS and to thinking through things that can be done to try to improve patient access to particular service lines or technologies. Now, in this presentation, we're going to use a lot of abbreviations. So we've put this nifty little slide here. I believe that we will be making the slides available to attendees afterwards. So I'm not going to go through all these abbreviations, but just know that when we come across them in the slides, we'll say the full name first and then reference the abbreviation to make it easier to follow along. Okay, all right, we're going to discuss the rulemaking process that CMS uses to establish payment rates. I believe we have a poll question for the audience asking how many of the attendees here have ever submitted a comment letter on either the inpatient, outpatient, or the physician fee schedule proposed rules. You can answer either yes or no, and I think it'll be interesting just to kind of see where most of our attendees fall on this question. And the reason why we're asking this is because the rulemaking process is how CMS establishes payment rates for the Medicare fee-for-service program. So as an example, today it's October 21st, which means that 20 days ago, CMS published updated payment rates for the inpatient prospective payment system. The inpatient prospective payment system, or IPPS for short, is how CMS pays for services provided by hospitals to inpatient patients that are covered through traditional Medicare. And sometime next week, before November 1st, we anticipate that the Centers for Medicare and Medicaid Services will publish the outpatient prospective payment system, ambulatory surgical care center, and the physician fee schedule final rules. We believe that CMS will publish this before November 1st because there is a statutory requirement that CMS publish those rules before that time. But it is worth noting that in the past, CMS has failed to meet that deadline. When that happens, CMS typically issues a waiver, and it's possible that they could miss this deadline with the government shutdown. But we are planning for CMS to have those rules ready by next week. Once those rules are published, it's going to have updated and finalized payment rates for outpatient hospital departments, ambulatory surgical care centers, and for services provided for the physician fee schedule. And those payment rates will go into effect January 1st of 2026. And I see we have the results from our poll question. It looks like 20% of the audience has submitted a comment letter before, but 80% have not. So hopefully we can convince the other 80% to start thinking about commenting on these proposed rules and the importance of doing that. So I'm really glad we asked that poll question. Okay, so once CMS publishes that final rule, what if there are things that you believe that CMS can do to improve patient access or help improve the care that Medicare beneficiaries receive? Starting in January of 2026, after everyone's back from the New Year's holiday, that's when CMS begins their pre-rulemaking efforts as they try to think through what policies and proposals they want to include in their upcoming proposed rules for the physician fee schedule and for the outpatient prospective payment system. During this time, it is possible for the public to request to meet with CMS during these pre-rulemaking efforts to lay out their recommendations for what they believe CMS should consider in the upcoming rule cycle. And in order to be effective and to use your time effectively when meeting with CMS, it's important to have data to support your advocacy positions. In April of 2026, CMS will be publishing the Inpatient Prospective Payment System, or IPPS, proposed rule for 2027. This is going to have proposed payment rates for services provided to Medicare beneficiaries in the inpatient hospital setting. Once that proposed rule is published in April, the public will have 60 days to comment on those proposals, which means that the deadline will be either June or early July for submitting those comment letters, depending on when the proposed rule is published. Then in July of 2026, CMS will be publishing their proposed outpatient prospective payment system, ambulatory surgical center, and physician fee schedule proposed rules. This will have all the proposed payment rates for services provided by outpatient hospital departments, ambulatory surgical care centers, as well as all services provided by physicians through the physician fee schedule. And again, once that rule is published, the public will have 60 days to comment on those proposed rules, which means that comment letters will be due in either August or September, depending on the date of when that proposed rule is published in July. It's also worth noting that for those who believe that CMS can make improvements to the Medicare Severity-Diagnosis related grouper, the MS-DRG system, that the public can make their requests to CMS around September of 2026. The other key deadline that's important to note is that October of 2026 is when the new technology add-on payment applications are due for fiscal year 2028. And Marla will be discussing the NTAP program later on in this webinar. Okay, so we provided that timeline just so that everyone has an idea of what to look forward to over the next year in terms of things to follow and comment on to make sure that they are promoting payment adequacy for their service lines and technologies that they care about. And I'm going to talk mostly about the inpatient prospective payment system for this webinar. We have a lot of expertise on the outpatient side and the physician fee schedule side, but since we only have a limited amount of time, we're going to focus on the inpatient side. And for all services that are performed for Medicare beneficiaries in inpatient hospitals, the way CMS establishes those payment rates is they assign every inpatient stay to a Medicare Severity-Diagnosis related group, or MS-DRG for short. So as an example, if you're hospitalized at a hospital and you're covered through the Medicare program, that hospital is going to submit a claim on behalf of that Medicare beneficiary to a Medicare Administrative Contractor, or MAC for short. That MAC is going to read in the claim. They're going to look at all the diagnoses that are listed on the claim, all the procedures that are listed on the claim, and other related information, and they're going to assign that claim to an MS-DRG. That MS-DRG represents the type of care that that beneficiary is receiving. So as an example, there are MS-DRGs that represent septicemia, DRGs that represent major joint replacement, spinal fusion, etc. And these DRGs are important because they're used for payment purposes. Every DRG is going to have a weight associated with it. And this weight represents the relative amount of resources necessary to provide a beneficiary on average for the care received for that inpatient stay. So these DRGs are constructed by CMS to kind of group together the care that beneficiaries receive, and they're designed to be clinically similar as well as to kind of similar in terms of the amount of resource uses. And CMS updates these MS-DRGs on an annual basis. So first, every year, CMS calibrates these DRG weights based on historical billing practices by hospitals and health systems. So as an example, for the current fiscal year, which went into effect on October 1st, CMS calculated those DRG weights using a combination of 2024 Medicare claims data and 2023 hospital cost report data. And CMS took these Medicare claims, took all the charges that are being reported on the claim, converted them to costs using hospital cost to charge ratios, And then once they calculated the cost for each inpatient stay, they then aggregated that information to calculate an average cost per inpatient stay by DRG. This information is really useful to have for market access purposes. It's a great way to look at what the typical cost is for an inpatient. You can also break out the cost by cost center. So as an example, one of the things that we do is we use this data to look at how costs are changing for individual DRGs. We can track out if these costs are changing because of changes in device costs or maybe changes in intensive care unit costs or whatever. But basically, CMS can also choose to modify the DRG system. They can create new DRGs, they can delete existing DRGs, they can change which DRGs procedure codes are assigned to. They can also change which secondary diagnosis codes are used to trigger a complicating condition or a major complicating condition. And CMS can also choose to change the surgical hierarchy, which was important this year for musculoskeletal diagnostic category, those MS-DRGs. Basically, the surgical hierarchy is used when you have an inpatient stay that has diagnoses that can map to multiple DRGs. CMS uses a surgical hierarchy to uniquely assign the claim to a DRG. So it's important to understand these concepts, but one of the things that we do is we actually purchase the exact same claims data that CMS uses for updating these DRG weights, which means that we can double check CMS's math to make sure that they're calculating the payment weights correctly. The other thing that we can do is we can use the same data to simulate how changes to the DRG grouper would impact payment rates for individual service lines or for different types of technologies. And when we do this, we use the MedPAR data, which is the same data used by CMS, and we do the same types of checks that CMS will consider when they're thinking through these DRG change requests and when they're thinking through how to update the DRG grouper. So this is very valuable data if you want to engage with CMS on modifying the DRG grouper. Okay, one thing that's very important to understand about how Medicare pays.
Devin, can I just interrupt? I think going back to the last slide, and the other aspect of getting the data is many times CMS will explain the changes that they're making to the DRGs, but there are many other times when they don't explicitly discuss those changes. They're technical, they're buried deep in the data, but with the data and knowing the rules that CMS uses to construct the weights, construct the DRGs, we can actually provide some explanations for what happened if payment rates unexpectedly increase or unexpectedly were lower. So I just want to point that out to everybody. Thank you.
Thank you. That's a very great point. So the other key thing to understand about how Medicare pays for inpatient services, Medicare uses the inpatient prospective payment system, which is a predetermined bundled payment rate. This is a fixed payment rate, and it creates a financial incentive for the hospital. If the hospital can keep their costs below that fixed bundled payment rate, the hospital profits. Hooray. If the hospital is unable to control costs and the costs are above that fixed payment rate, then the hospital is going to lose money on that inpatient stay. This means that the way that Medicare pays for inpatient services, it creates a very strong financial disincentive to use any new technologies that raise costs. This means if you're a hospital or a health system and you're evaluating whether or not to use new technologies, or if you're a medical device company trying to make sure that your technologies are attractive to the hospitals, the things that are worth considering are, one, if the technology qualifies for new technology add-on payment. If the technology qualifies, that is a way to offset some of the costs to the hospital associated with implementing the new technology. The other consideration is whether or not the technology helps to reduce hospital costs. Again, there's a strong financial incentive for hospitals to reduce costs, or anything that can either shorten length of stay or remove the need for existing technologies would be beneficial to the hospital. Any diagnostic technologies that help to improve the diagnosis of certain conditions that are underdiagnosed, that can improve DRG assignment, as well as any technologies that have strong clinical backing from physicians or that help to attract new patients or that can provide competitive advantage to that hospital over their competitors. Those are things that hospitals would be interested in. So in terms of promoting payment adequacy through the rulemaking cycle, I think the key themes are for health systems and medical device companies. They want to make sure that they are aware of CMS proposals that will impact their hospital, that will impact their service lines, that will impact their technologies, and that they are commenting on those proposals effectively using data. That you have to have a data-driven argument to be successful with CMS. It's also worth thinking about if there are any improvements that can be made to the DRG grouper that CMS uses to help improve patient access and improve payment adequacy for a particular service line or for your technology. And then for a device manufacturer specifically, it's important to think through any payment pathways that are appropriate for your technology. And I think that is an excellent segue into Marla's portion of the webinar.
Thank you, Devin. So I think, Ben, this is a great time for our second polling question before I go into talking about the new technology add-on payment application process, as well as other changes that are happening under the inpatient prospective payment system, but really creep into the other prospective payment systems Devin mentioned, the outpatient and the ASC. So I'll give you folks a minute to look at this question. Have you successfully applied for NTAP status as a non-breakthrough technology? And don't worry if you don't know what breakthrough is, that's okay. I will mention what that is, but please answer the question if you are able. So today I'm going to spend some time talking about NTAP, and then I'm going to talk to you all about the inpatient only list and how these sort of changes, the NTAP is not a change, it's been around for a really long time, but how the inpatient only list going away might impact other payment systems and how that's going to change the market. So I'll start with NTAP. The new technology add-on payment option application has been around for a long time. As Devin mentioned, there's incentives for hospitals to always be cognizant of reducing costs, being efficient. The NTAP is sort of a counterbalance to that. The inpatient prospective payment system allows for up to 1% of the budget, 1%, to be used for NTAP payments. That is a lot of money. 1% of the IPPS is about $1 billion. And to my knowledge, NTAP payments have never even come close to hitting that top threshold. Everyone likes NTAP in terms of the hospitals, the manufacturers, because it's essentially free money. It is outside of the budget neutrality process. Putting money towards payment for NTAP does not take away from the DRG payments. So it's only additive. So everyone loves this, and all folks out there who can take advantage of it really should. There are 3 criteria for a typical NTAP application. The newness, you must be a new product on the market. For the substantial clinical improvement, you must be better than what's already out there, and cost. And CMS has a very particular formula for assessing that you are greater cost than what's available. And we at McDermott Plus help our clients apply for NTAP all the time. I've run many NTAP calculations myself, and so we are experts in being able to provide that for you. We have the polling questions. So have you been successful? We have one special company out there that's been successful. Way to go for the non-breakthrough status. We have a lot of folks that were not, and we have some that are considering. So this is a good opportunity for me to talk to you about what makes breakthrough status really special, and we can go to the next slide for that. So when you have breakthrough status, you actually get to automatically qualify, and there's an asterisk there, automatically qualify for the newness and the improvement category. So you get to only have to really focus your application on the cost criteria. There's the asterisk, and I'll mention that now for breakthrough status. You automatically will qualify with breakthrough status, but the newness is met so long as your marketing authorization is not more than 3 years prior to NTAP, the NTAP start date for your breakthrough device, or the QIPD, that's the infectious disease version of the technology. So Great to have breakthrough status for NTAP. It really helps make your application much more compelling in the sense that you don't have to put up a lot of evidence for clinical improvement. But that's not to say that non-breakthrough devices or other technology shouldn't apply. You should just realize that you'll have to put in the effort to reach, excuse me, that clinical improvement category. Let's go to the next slide. So Devin went over a lot of good dates for following the comment period, and I'm just going to, the purpose of me going over this timeline with you all is to make sure you understand that this is done in advance. So this slide that you see really lays out what the 1 year looks like, and that was for this application cycle. So imagine that you would have this exact same timeline, just push forward a year, because the application for this year actually just passed. So everyone who applied this year, the deadline for that was early October. Their NTAP, if their application is successful, would begin October 1, 2026, the start of the federal fiscal year 2027. If you want to apply for NTAP, you can get started now, but know that the next application deadline would be early October 2026 for a start date of October 1, 2027. That would be fiscal year 2028. So I'm telling you all of this so you understand that everything has to be done in advance. You have to think, if you don't have breakthrough status, you have to think about that clinical improvement category. If you do have breakthrough status, you're really going to want to focus in on the cost criterion piece. So you can see the cadence here. Along with your NTAP application, you'll also want to be prepared to submit an ICD-10 PCS code. And that's because CMS needs a way to identify you in the claims in order to pay the NTAP. So that's very particular. Even if there's an ICD-10 code that you think sort of represents your technology, that's great, but you really will need to apply for your very own code so that you can be paid accordingly. Other important aspects of this timeline, the deadline for the FDA decision. Folks that are applying for this year, they have to have FDA approval or anticipate FDA approval by May 1st, 2026. So don't apply if you know that your FDA schedule is way off. If there is no way that you're going to get FDA approval by, say, May 1st, 2027, then you probably are not ready to apply for the next year, for that fiscal year 2028 cycle. So keep that in mind. Let's go to the next slide. So hospitals can leverage NTAP to mitigate losses. This is important. The NTAP payment will never be enough to cover the full cost of adopting the technology. However, hospitals should know that they can receive NTAP and outlier payments for really high cost cases. So that's in play. Outlier payments are always in play. NTAP is additive. The NTAP represents about by statute, 65% of the cost of the new technology, or the lesser of whatever you're going over on the charges reduced to cost. So with that in mind, 65%, you're never going to reach that total 100%. But again, just to emphasize, the outlier payment are in play. And so that will help you also, as hospitals work with manufacturers to adopt new technology, there is that an added payment able to be received through outlier. So what can you do? Actions for medtech companies. You can build a custom calculator that compares the estimated hospital-specific costs to payment. So if you have customers that don't really understand NTAP or really want to know how the dollars are going to break down, this can be modeled. We can produce these calculators tailored to your technology, even your branding, so that they can be in front of customers, able to tell that story, how NTAP payments and outlier payments will help for those high charge cases. You can prepare this tool in advance of your NTAP start date so you can be ready to market as soon as you get your NTAP approved. For hospitals, hospitals can track what payments are you currently receiving for new tech. Is your coding and billing doing justice by what NTAP are available out there that you know your hospital system is using? You can also start to look at how the NTAPs out there are going to start changing your DRG payments. Obviously, NTAP is a small portion of what contributes to DRG payments, so the needle maybe not move very much, but there is the ability to understand how that data is flowing through, specifically for your health system or for the nation at large. Let's go to the next slide. We can also track the uptake of new technology, and this is another way that having access to timely data is so important. So you can tap into that Medicare claims data to see the payment amounts that were made. You can see what the coding looked like. Was it correct? You can see what the charging practices look like for customers, as well as when there's some maybe mistakes. Unintentional miscoding happens all the time. And so you can look back for a med tech company, you can see, I know I was selling to these customers, but who's actually using my code correctly? So that is a really powerful tool with the data. And of course, you can track that volume as it's being as you're marketing, as you're selling, see how it's flowing through. This is specific to the Medicare fee-for-service population, just to remember for NTAP, as well as, like I mentioned before, seeing how the uptick of use of that technology or other similar technologies is changing the DRG weights. You can also do a deeper dive into individual hospital margins. As Devin mentioned before, not only do we have access to the claims data, we also have access to the cost reports. And by combining those two really rich data sources, we can tell the story of how hospitals are doing financially when they take on these new technologies. Let's go to the next slide. So now I'm going to move into talking about the payment policies that are affecting the site of service. What kind of site of care shifts can we expect? Let's go to the next slide. So we haven't received a final rule yet, but dissolving the inpatient only list was proposed to start in 2026 with the movement of about almost 300 procedures, most of which were musculoskeletal related, off the inpatient only list and onto the OPPS for payment purposes. Some of you who track payment policy in the Medicare space may remember that this was actually proposed and finalized under the Trump administration back in calendar year 2021, but the Biden administration rescinded this policy. Now it is back again, and the proposal is to dissolve the entire inpatient only list over 3 years. CMS gave a number of reasons why they were doing this, with in terms of medical technology advancements, the fact that it was always meant to be the decision of the surgeon in the hospital, that there are already safeguards in place, and it may lead to even lower payments for beneficiaries. The process that CMS went through to propose the dissolving of the IPO list was also carried through for the ASC covered procedures list to make sure that a lot of the same procedures that are now going to be paid under the OPPS would be paid under the ASC. Let's go to the next slide. So what does this all mean? These visuals help you understand that as the elimination of the inpatient only list shrinks over the next 3 years, if this proposal is finalized, you're going to be having a lot more decision making being done for who is inpatient, who is outpatient, what cases are appropriate to move to outpatient, who will the decision makers be? It should be, of course, the physicians involved, speaking with their patients, figuring out what works best for care. But how do we know there might not be some hardship in that decision-making process? How do we know that other sort of forces won't come into play for helping physicians make those decisions? For the expansion of the the ASC covered list, you have the opposite going on. You have what was a shorter list expanding into a very long list, and then having the decision of, should a patient stay an outpatient, or would it make sense for that patient to just be in the ASC? So let's move on to the next slide, and I'll talk about this a little more to give you a sense of scale. This is not volume. We don't really know what the volume will be like. We can model it, but we will not know how sites of service change until we start seeing these policies in action if they are finalized. But just to give you a sense of scale, the number of procedure codes make up about a quarter of the number of procedure codes currently paid separately under the OPPS. That's a lot. We're talking about thousands. For the ASC, same idea, about not as big, but about an eighth of the current codes on the ASC list for 2026. We don't know how much bigger the ASC list is going to get. It could start looking like the piece of the pie on the OPPS side if a lot of procedures are getting the clear to go on the covered procedure list for ASC. Now, of course, some procedures that are coming off the inpatient only list will not move. Even if they're technically paid under the OPPS, somebody getting a heart transplant may never be done in the outpatient setting. We don't know for sure, but just know that just because it's on the outpatient list or off the inpatient only list doesn't mean it has to be done in the outpatient. It's just that physicians and decision makers are given that option, and there will be a payment amount attached. Let's go to the next slide. So I mentioned earlier that there might be some other forces at work helping physicians and other decision makers to make the choice, to make the determination of whether a patient goes inpatient, stays inpatient, goes to the outpatient, or goes to the ASC. And CMS has already started putting these different mechanisms in play. There's currently already prior authorization for certain outpatient department services happening. That's been ongoing, that already happened. So there's already controls in place for utilization and site of service in that respect. CMS has also introduced one new payment policy, a new policy which is called WISER, the Wasteful and Inappropriate Service Reduction Model. This is for essentially AI to come in and start trying to make these determinations, one, to lift burden off of hospitals, but also to instill these utilization controls. Right now, WISER is limited to certain clinical areas, but you wonder if down the line there will be more of this effort, very similar to how private insurance really works today. Let's go on to the next slide. So how do you prepare for these changes? First off, you have to protect your reimbursement in the new sites of service. The first way to do that is to understand how the OPPS and the ASC rate setting policies work, and we can help you with that, of course. What is really on everyone's mind is how CMS, remember I showed you those pie charts where 1/4 of the codes are going to come onto the OPPS from the IPPS over the next 3 years. That's a lot of codes. They're going to need new APCs potentially. There's CMS, when a few codes come off the inpatient only list, their assignment is determined from a lot of clinician input and other stakeholder input, and that's just a few codes every year, and it takes time, it takes comments, it takes meetings potentially. How will they manage to take off thousands of codes? When this policy went through before under the Trump administration, the hundreds of musculoskeletal codes were assigned to existing APCs based on a buddy code. They did no cost analysis for that assignment. They just looked at clinical similarity via buddy code. When you're taking off thousands of codes, the process becomes much more complicated, and maybe CMS would listen to stakeholders doing modeling of costs, combine with a clinical analysis in order to foster proper assignment. So getting ahead of these assignments is key. You want to pitch an APC assignment choice potentially before CMS chooses for you if you are a device manufacturer with certain procedures that you want to protect as they travel from inpatient to outpatient and potentially outpatient to ASC. We can also model the MS-DRG payments, which could change as cases flow out of the entire IPPS into the OPPS. Imagine you're a health system. You have 1 to 2 day stays that are currently inpatient. What if a lot of those start flowing to the outpatient? What does that mean for your margin under Medicare fee-for-service? Note that under the inpatient, hospitals get bumps in payment for dish, for teaching, for other aspects of geographic adjustments. Not all of those adjustments are going to translate to the outpatient. So hospitals could, even if they're getting the exact same payment rate, which there's no guarantee, payments may go up or down just because outpatient is not subject to these adjustments. So aspects of these policies can be modeled so that stakeholders can really understand and write a comment letter. I know a few of you have already, maybe more of you will want to be doing that as these major changes come about. Also, of course, if you are a medtech company, you're going to want to monitor these impacts on your competitors. So just be aware that all of those are good ways to prepare as these changes come about. Let's go to the next slide.
Before we go to the next slide,
Yeah.
a couple other points I think to remember, right? So the preparation for these changes that we're talking about here relate to the actual policies and the payment rates and modeling those. But there's a broader business impact that companies should be mindful of. And we've advised some of our clients about these changes such as the impact on Salesforce, right? If you've got a procedure that's mostly confined to the hospital, but now it can be done in the ASC, how does that affect the sales coverage that you might have in place? How does it affect potential selling price? ASCs typically tend to end up negotiating better prices from medtech companies than hospitals typically do. So thinking about some of those other sort of business related broader changes is also important. And again, I've talked to several of our clients to think through the impact of this sales education, right? Things of that nature, talking to your customers. So monitor the impact on your customers. Are your physician customers, for example, more inclined to do the procedures in the outpatient, even though they could do it in the ASC? Or are they inclined to shift over to the ASC? So thinking a little bit broader in terms of the overall impact on the business, it's better to start earlier so you can be ready for many of the changes that are going to come down the pike.
All right, so just to reiterate the conclusions in terms of our presentation, and we're also interested in any questions from the audience. It's important that stakeholders be proactive, they comment on the rules that are coming out. It's also important to understand how the market is changing, and there's a lot of data available that can be used. So as an example, Marla talked about how we can use data to look at once the inpatient only list, if it is kind of removed, like we can look at the site of service shifts that are changing with our inpatient outpatient claims. We can also use the MedPAR data to simulate how changes to the DRG group would impact payment rates for individual service lines. I'll stop there if there's any questions from the audience we want to address.
Has CMS published a proposed list of what codes will be moving? If not, do we know when that list will be published? And I'll just sort of I'll qualify this a little bit. I think maybe we should address both lists, right? They're two separate lists. And so Marla, I saw your hand go up if you'd like to address that question for both lists.
Yes. So CMS has made public the list that is initially proposed to go off the inpatient only list and on to the outpatient prospective payment system. It's about 285 codes. They have also made public the list of codes they're proposing to move on to the covered procedure list for ASC, along with their proposal to dissolve the criteria that is on what can go on the ASC covered procedure lists. So that initial proposed list for 2026 has been made public. CMS has also stated their intention to dissolve the entire inpatient-only list. The inpatient-only list, the entire one, is available online, so you can see all the codes that are currently on the inpatient-only list. They have not said how they will move codes over. They're looking for stakeholder feedback for that, of what categories of codes or groupings or what have you should move over, in what cadence. Is 3 years a long enough time? That kind of thing. They're still looking for stakeholder feedback. So we might see some of that commentary in the final rule, but they probably will not go through the next wave until the rule cycle for the following year, 2027.
Yep, thank you. And we had another follow-up question.
Oh, yeah, let's look at the follow-ups.
Yep, so somebody's asked if we can share the list or send us a link. And so what I'll say is, right now on the screen, you see our email addresses. So happy to send that list if you send an email to any one of us, and we can share the list, both lists, actually, both the inpatient only list as well as the current ASC covered list.
Yes.
Another question, are the average national payment data per DRG available openly? I think the answer is yes, but Marla, Devin, do you want to take that one?
Yeah, I can take that one. So it is possible to calculate the national payment rates for individual DRGs using what's called Table 5, which has the payment rates for each DRG, and Table 1, which has the national payment rates. We actually have a fun little dashboard that's hosted on the McDermott Plus website, where it has a little drop-down menu where you can pick any MS-DRG and it will show what the national payment rate is for that DRG. That dashboard will also show the breakdown in terms of the average cost per inpatient stay for that DRG, broken out by 19 different cost centers. Hypothetically, if you want to know what the average payment that's being paid to actual hospitals, CMS does have some public use data sets which you can use. We also have Medicare claims data. Those payment rates will be adjusted based on hospital specific factors, including their wage index and other information. So those are other ways to get at that information.
Great.
Yeah.
I think go ahead, Marla.
I was just going to add to that. Okay, average national. Okay, that's fine. I was going to say that if you wanted hospital specific payments, that's either something you look at for historical claims data, or we know the very intricate formulas for calculating those for a given fiscal year.
Yeah. Another question, I think, related to the shift here. So it looks, based on what they're saying here, based on your presentation, it looks like the administration wants to shift, Medicare wants to shift services to the outpatient side. Are there other steps CMS is taking to do that?
Yes, there are, and I'll let Devin speak to this as well, but CMS is also trying to push forward site neutral policies, which mean that there's, for certain services, the payment will be the same based on where the patient gets the service. For this cycle, CMS has proposed doing this for drug administration codes for certain outpatient departments, the off-campus ones. But that's not to say that CMS won't expand site neutral policies in the future and possibly the near future. And Devin, if you want to add anything to that.
Yeah, that's a great answer. In the outpatient proposed rule, CMS also included an RFI, a request for more information. And they are considering potentially looking into site neutral payments for imaging services, as well as certain services that are predominantly done either in the ambulatory surgical care center or in the physician office. It's also worth noting that starting January 1st of 2026, CMS will be implementing the Transforming Episode Accountability Model, or TEAM model for short. And this model is specific to major bowel procedures, lower extremity joint replacement, spinal fusion, and coronary artery bypass grafts. This demonstration is going to be triggered by procedures that are done in either the inpatient or outpatient setting. And for those procedures that can be triggered by either the inpatient or outpatient setting, the way they're pricing those services, it creates somewhat of a financial incentive for hospitals to shift that care into the outpatient setting. So that's a great question.
And we have three other questions. Let's get to these very quickly. Somebody asked if we can comment on the relationship of this presentation to the TPNIES program. So for those that are not familiar, the TPNIES program is a transitional payment for new and innovative equipment and supplies for dialysis. So conceptually, it's very similar to the NTAP program. But the timelines are slightly different, et cetera. And if you'd like more information on it, please just reach out to one of us. Here's a good question. Assuming applying for NTAP is not a guarantee it will get approved, what recourse do companies have if rejected? Comment letter, appeal, any thought on this? I'll take this one on because I've had an NTAP rejected back when we were at Boston Scientific. And again, frankly, there's really no appeal per se. What you can do is submit the application again with hopefully additional data and hope for a better answer. But you also have to be mindful of when you've launched and whether you're still going to be considered new, particularly if you're not a breakthrough device, because as Marla pointed out earlier, once you're past a certain window and the data for your technology is in the claims data that Medicare uses to set the payment rates, then you're not going to qualify regardless of whether you're a breakthrough or not. Next question. What is required to prove substantial clinical improvement for NTAP application? Clinical study only. I'll take a shot at this and then maybe ask Marla and Devin to supplement. I'll show my age and note that I was at CMS when we developed the program, including the list of examples and everything. So yes, clinical study, peer reviewed certainly helps. There's other data CMS is certainly willing to look at. But it is a very high bar to prove substantial clinical improvement. It always has been, and it remains so until breakthrough status came into play, which is why when Marla talked about it being important, I don't think anyone can emphasize enough how important it is to get breakthrough status. So yes, clinical study, but other studies, other analysis are helpful, but don't bet your farm on only non-clinical studies being sufficient to show substantial clinical improvement. Did Devin state BAL or bowel? Devin, you want to take that one? I'm not quite sure when you
Yeah, so I mentioned the types of episodes that can trigger a team episode, and it would be major bowel procedure,
Okay.
lower extremity joint replacement, spinal fusion, and coronary artery bypass graft. Those are the things that can trigger a team episode.
Okay, so it's bowel as in BOWEL. Okay. Ben, how are we doing on time?
We've got just a couple of minutes left here, about 3 or 4 minutes left, I would say.
All right, let's see if any other question pops
There is,
up.
there is
Oh,
one
okay.
about the bit. Can you go into a bit more detail on the cost side of NTAP approval? Sure. CMS wants you to compare the cost of cases using your technology to a threshold at the DRG level when you apply. And I state this, it's very formulaic. It's not a creative analysis. It's a follow the steps and show your cost. The tricky thing I think for applicants is to understand that when you're talking about NTAP, what you don't want to emphasize or think that it's going to help is that you reduce costs. If you're saying in your clinical improvement that you save 3 days, that you get folks out of the hospital instead of the current of 7-day stay, you reduce to 4, you would have to put that forth in the cost analysis. The purpose of the cost analysis is to really gauge what the cost of a stay using your technology looks like, but it's okay if you're not showing cost effectiveness. So it's not about cost effectiveness. It's really about emphasizing, do your costs go above a certain threshold that CMS sets? Also, I've gotten questions from applicants about how does that relate to pricing? So in some cases, you're going to pass that threshold. Cases using your technology are just naturally going to be more expensive. They're going to have higher costs than the threshold. And you may not even need the price of your technology to bump that up. However, for payment purposes, you will have to share your technology's price. So you can choose whether or not you want to include it in the cost analysis to show that your cost is here, surpassing the threshold. You can choose whether to add that to the cost analysis or not. You may not need to, but you will eventually have to give CMS your pricing so that they can pay you accordingly.
All right. Thank you very much, Marla and Devin. Appreciate that. And thank you very much to Medical Alley and Ben for hosting the program. We hope you found it enjoyable, and I'll turn it over back to Ben.
Well, Parashar, thank you. And I'll extend my thanks to the McDermott Plus team here too. I think the coordination for this has been great, and I really appreciate Marla, Devin, and Parashar for sharing their time today, their expertise, and for also graciously sharing their contact information too, which we'll be able to pass along to everybody in attendance here today. So thank you to the McDermott Plus team. Thank you to everybody for attending, and have a wonderful rest of your day.